There's no way I could cover oncologic emergencies in any depth in 30 minutes. So I'm just going to hit the high points of it, and there's additional information in the PowerPoint presentations that you can take home. Not going to worry about that. Emergency being a crisis, unforeseen set of circumstances that require immediate action. And those are the ones that we're going to cover in very brief detail this afternoon. And we're going to start out with the hypercalcemia malignancy. You got three types of hypercalcemia. You've got the hypercalcemia that's related to the parathyroid hormone, related protein, and that you see not only in malignancies, but you can also see that in the hyperparathyroidism. Those are the types of cancers that you tend to see this particular variation of the hypercalcemia. Then you got abnormal vitamin D production, where all of them have some kind of level of osteoclastic bone resorption going on. But when you look at myeloma and lymphoma, you see it, again, an abnormal vitamin D production. And then the local osteolytic hypercalcemia you see in cancers that tend to have an extensive metastasis of the skeletal system. And a lot of these, the breast, myeloma, lung, prostate, you're going to see a little later, because these are the types of ones that love to go to the bone. Now, when people present with hypercalcemia, we usually look at the corrected calcium, can be greater than 12. It's almost not so much the number as it is the rapidity of the increase. If someone, over the course of time, over the course of weeks, their calcium level increases, they may very well be asymptomatic until it gets to a certain level. But if somebody who a week ago their calcium was 9, and then a week later they're 12, they're going to be more likely to have the symptoms, the altered mental status, the constipation, the seizures, the moans, stones, and groans that everybody has grown to know and love going to school. And so when we talk about the effect on the kidneys, the renal system, the amount of calcium overwhelms the ability of the kidneys to reabsorb the calcium level. And then the calcium precipitates into the tissues and you end up with renal failure. With the cardiovascular, it goes and affects the nerve impulse in the cardiac muscle. You end up with risk of getting cardiac arrhythmias and cardiac arrest. And the same principle applies with the generalized muscles. How do we treat it? If it's mild, you just want to make sure they don't get dehydrated. So oral fluids, activities. But if there's severe hypercalcemia, there's 3 things you're looking at, 2 more than a third one, and we'll talk about the exceptions for the third one. But you want to rehydrate them, you want to increase the renal calcium excretion, and you want to decrease the bone resorption. And how do you do that? First, you hydrate. You give them normal saline IV fluid therapy. You're looking to give maybe up to 3 liters, and you're running it at 200 milliliters an hour in order that they diurese that 100 milliliters per hour. The renal calcium excretion, where you talk about loop diuretics, that's going to be where if the person has heart failure, they have renal insufficiency, because obviously if you give somebody 3 liters at 200 milliliters an hour and they got heart failure, you got the risk of exacerbating that and you got fluid overload. So that's really the 2 types of patients that you would consider loop diuretics if they have hypercalcemia. And then the third, the decreased bone resorption, you're going to use the biphosphonates, the pamidronate, the zolendronate, because remember the last slide we talked about the cardiac effect, you're going to put them on telemetry, you're going to get EKGs, correct the electrolytes, not collect the electrolytes, correct the electrolytes. And then you can do the calcitonin, that's going to antagonize the effect of the parathyroid hormone, but that's really has a short-term effect, 12 to 48 hours. What you're looking at is, you're looking at the zolendronate, the pamidronate, over the course of time to reduce the calcium. And if I get this done in less than 30 minutes, I got one story on the calcium that kind of touches all of that. But I'm trying to keep within the 30 minutes that Katrina made me stay with. She's busy. Tumor lysis syndrome, it's a syndrome of metabolic disorders. What you have is you have a particular set of tumors, particular set of malignancies, where you have a high degree of tumor cell death, and as a result of the tumor cell death, you have this release of the electrolytes, release of the uric acid, and you tend to see that in tumors that are, or cancers that are poorly differentiated, that have a high tumor burden, and that are sensitive to the treatment they're receiving. What happens is you get a release of potassium. If you go back to your cell physiology, cells try to hold on to the potassium while the sodium's trying to get into the cell. But you have that cell death, you have a massive release of potassium, you have a massive release of phosphorus, and your uric acid increases. And all this will happen anywhere from 12 to 72 hours after the chemotherapy or radiation therapy. It can happen to either one of them. You see the symptoms. I'm not going to read through all the symptoms. You see the labs. The diagnosis is going to come if the person has hyperuricemia, hyperphosphatemia, hypocalcemia, or hyperkalemia, as well as renal failure. All those are going to play a role, whether it's a lab tumor lysis syndrome diagnosis or a clinical tumor lysis syndrome diagnosis. Hyperuricemia, of all of them, this is the most common metabolic abnormality. You've got uremia, you've got acute renal failure, you've got metabolic acidosis. If you remember the mnemonic mud piles, the U in mud piles is uric acid. You see the signs and the symptoms with hyperuricemia. Hyperphosphatemia, symptomatic hypocalcemia. There's an inverse relationship between the phosphorus level and the calcium level. Phosphorus level is high, the calcium level tends to be low, and vice versa. But with hyperphosphatemia, you also have acute renal failure and cardiac arrhythmias. Hypocalcemia, you're going to have the muscle cramps, the seizures, mental status changes, as opposed to the hypercalcemia where you have the QT, the shortened interval. With hypocalcemia, you have the prolonged QT interval. You also have Trousseau's and Chvostek's. Trousseau's is that carpal pedal spasm, and Chvostek, the facial spasms. They're the ones you normally think of with hypocalcemia, but as far as the specificity and the sensitivity, they're not really detailed enough. They don't have that high level of specificity and sensitivity to count on that. And then the hyperkalemia, the muscle weakness, the EKG changes are what? Yes, peak T waves. And the peak T waves lead to QRS widening, which lead to cardiac arrhythmias, which can lead to cardiac arrest. So you want to keep track of those. And I'll show you how to treat all those in just a second. Tumor lysis syndrome, whether it's laboratory or clinical, the laboratory is if you have 2 or more of those electrolyte abnormalities and the uric acid is elevated. Clinical tumor lysis syndrome is the diagnosis of lab tumor lysis syndrome plus either renal failure, cardiac arrhythmias, seizures, sudden death. That's how you treat tumor lysis syndrome. You try to avoid it. And you avoid it by giving them normal saline IV fluid and an allopurinol prophylaxis. If they get it, you treat the individual electrolyte abnormalities, treat the renal failure, treat the cardiac arrhythmia. You basically treat the lab or the clinical tumor lysis syndrome. Specifically for the electrolytes, the hyperuricemia, you're going to do all these things. The hydration with IV fluids, you may give them some diuretics. You either decrease uric acid production or increase uric acid destruction. With the decreasing production is with allopurinol, with increasing it, it's respiricase. How do you determine which one to use? It all depends on the white blood cell count, the uric acid level, and the LDH. So if you're, just one example, if the white blood cell count is greater than 50,000, if the LDH is 2 times greater than the upper limit of normal, and if the uric acid level is elevated, you're going to give them respiricase because you want to destroy the uric acid that's there. If the uric acid level is within normal limits, you're going to use the allopurinol. For hyperkalemia, if you have it, first recheck the lab to make sure it's not a lab error. That happens a lot with potassium. If it's less than 6, just avoid the PO. Obviously, don't give them IV potassium. Check to see if they're on things like Septra, Bactrim, ACE inhibitors. If it's moderate, if it's 6 to 7, you keep doing those things. Put them on telemetry just to monitor so they don't progress to the peak T waves and the cardiac arrhythmias. And you can give them Kayexalate, sodium polystyrene sulfonates Kayexalate. That's a long-term way to reduce the potassium. If it's severe, if it's greater than 7 and they're symptomatic, you do all of the above. Plus, you give them the calcium gluconate. You can give them 1 to 2 grams. You can give them the combination insulin, the D50. And you may need to get nephrology involved if they need to have hemodialysis. And like I talked about, the inverse relationship between hyperphosphatemia and hypocalcemia. If they have hyperphosphatemia and they're symptomatic because of the calcium, you treat the calcium. If that's fine, you treat the hyperphosphatemia and then just monitor the calcium. Told you, this is going to be a down and dirty presentation. SIDH, inappropriate secretion of antidiuretic hormone. It's the normal volemic hyponatremia. It's where you have an impairment of the excretion of the free water. You have more fluid staying in the body, diluting the sodium. Most commonly is seen in people with small cell lung cancer, the bronchogenic carcinomas. 15% of the patients that have small cell lung cancer will have SIADH, and they'll present with those presentations. You can see the labs. The serum sodium is going to be decreased. The serum osmolality is going to be decreased from where the normal levels are, but the urine sodium and urine osmolality is going to be increased. The treatment for that is fluid restriction. Usually we do about 1.2 to 1.5 liters per day that we limit them to. Hopefully that actually happens in the hospital. Somehow they seem to get above 1.5 liters. Don't know how they do that. You can do diuretic therapy, and if they have chronic SIADH, you may see them starting demeclocycline. And the 2 things you want to avoid is 1, the central pontine myelinolysis and fluid overload. So if the sodium level is less than 120, your nephrology, and get nephrology involved with this one. They may start them on 3% normal saline, but then once you get to 120, you're going to cut off the 3% normal saline and do fluid restriction. This one I'm going to be real quick about. Hyperviscosity syndrome, elevated levels of compounds, and most commonly with proteins, which are in the plasma. You can see that in polycythemia, where you end up with a reduced blood flow. You have the leukemia with the elevated white blood cell count. Sickle cell, where you have a deformed cells. The monoclonal gammopathies and the Waldenström's and the multiple myeloma. And people with hyperviscosity can develop sepsis. Those are the symptoms. Lab, you measure the serum and plasma viscosity. And the treatment depends on the cancer that the person has. If it's myeloma, you do a plasmapheresis. If they're leukemic, you give them a leukapheresis. And if they have polycythemia, you do the phlebotomy. It's a nice algorithm. We're not going to go through it. I'd be here for 60 minutes then. But that's the pathophysiology of hyperviscosity syndrome. And there, One of the results of hyperviscosity is a retinal vein thrombosis, which these are pictures of the retinal vein thrombosis. Herniation syndrome. Basically, herniation, what you have is you have increased pressure in the brain. Actually, I should have Ashley and Caitlin up here talking. Increased pressure in the brain and infecting the blood supply, among other things. And you end up with an increased intracranial pressure, courtesy of the vasogenic edema, hemorrhaging, cerebrospinal fluid obstruction, infections, abscesses, thrombosis, all can contribute to the increased intracranial pressure. Vasogenic edema, brain mets from primary cancers outside the primary brain. If somebody has a primary brain cancer, they tend to have slightly less edema than if it's a metastasis from another primary outside the brain. Cerebral hemorrhage, melanoma, choriocarcinoma, renal cell, papillary thyroid cancer, all are very hemorrhagic. You have a high risk for bleed. And then just the presence of the lesion can cause CSF obstruction. Infections can play a role in that. Abscesses can play a role in that. And then patients with cancer tend to have a greater propensity for developing thrombosis, whether it's a DVT, whether it's a pulmonary embolism. They have that increased risk for that. And so you've got this concern for cancer-induced hypercoagulability. Then on the flip side, you got the people who have the clot and they have to be on anticoagulation. So now they're also at risk of increased bleed. So they actually get it on both ends. When we talk about herniation syndrome, there are really two classes. You got the supratentorial or the infratentorial. The central and the uncal are the ones that are supratentorial. They're above the tentorium. You see the symptoms there. The central is if you have two temporal lobes go through the tentorium, putting pressure on the brainstem. The uncal is one temporal lobe, again going through the tentorium, putting pressure on the brainstem. And both of those can also cause something what's called Durette's hemorrhaging. They can tear the pontine or the basal arteries in the brain. And then the final one is the tonsillar, which is, what happens with that is it passes through, it's in the cerebellum, where it passes through the foramen magnum, and then that presses on the brainstem and the cervical spinal cord. There's a picture of the uncal one. Let me try the green thing there, right there. That's an example of the temporal mass coming through the tentorium and putting pressure not only on the brainstem but on the cerebellum. There's the symptoms. Headache, most common at night. They're lying down, they get up, they have a headache, it's relieved with emesis. The other signs, you got the ocular findings, the papilledema, blurred optic disc margins. There's a reason why I'm saying those two things. Cushing triad of hypopnea, which is shallow breathing, hypertension, bradycardia, abnormal posturing. That's indicative of severe brain damage and a poor prognosis. Depressed levels of consciousness, you're looking at a Glasgow score of between 3 and 5. The reason I mentioned the papilledema and the blurred optic disc, I had pictures, so I had to refer to them. There is the optic disc. You can see it on the right, that is blurred. Should be a little sharper than that. When we diagnose intracranial pressure, the gold standard is actual direct measurement. You've got, what are the three measurements you got? All of a sudden I went blank, but I got them. You've got the intraventricular catheter, you have the subdural screws or the epidural sensor. I almost did the epidural screw and the subdural sensor, but now I got everybody confused. It's the subdural screw and the epidural sensor along with the intraventricular catheter. And what you're looking to see, or hopefully not see, is the reading greater than 20 millimeters of mercury, because then that's pathologic. As far as studies, you're looking more at an MRI with gadolinium. The reason being is it can do a better job of differentiating whether it's tumor, whether it's thrombosis, whether it's an infection. Treatment, dexamethasone, loading dose, and then you give them scheduled. Usually we'll do 4Q6. Head elevation, isotonic fluids, because you want to keep the cerebral perfusion pressure between 60 and 75. And then you want to keep the hyperventilation to keep the partial pressure of the CO2 between 25 and 30. IV mannitol, get neurosurgery involved, see whether the patient's a candidate for decompression, and obviously supportive care. Now we get into the other thing in the neurosurgery world, spinal cord compression. All these things can cause spinal cord compression. You give somebody an epidural steroid injection, you hit a vessel, and the person doesn't have cancer, they can get it with hematoma. Herniated discs aren't limited to people with cancer. And vertebral fractures also aren't limited to people with fracture or with cancer, but they do get them. And then you got metastasis. And when we talk about the ones that like to go to the bone, there's this phrase I learned years ago, P.T. Barnum loves kids, because you're talking prostate, thyroid, breast, lung, and kidney. There's other ones that do go, but those are the ones that you will tend to see. Spinal cord compressions end up having an overall reduction in the quality of life for the patient, also reduced survival. Up to 90% of the metastasis in the spinal cord you're going to see in the vertebral body, the remainder in the epidural. And when you look at where they tend to present most often, 70% are in the thoracic, 20% in the lumbar, and 10% in the cervical. And don't forget about leptomeningeal disease. The symptoms, they can come on quickly, they can come on gradually. The back pain is the most common symptom. It can be local, it can be radiating pain, weakness and sensory paresthesia along the dermatome. When we talk about the differentiation between thoracic and lumbar, thoracic, you tend to have this weakness and paresthesia in an ascending fashion. You tend to have dysfunction of the sphincter late in this whole progression of symptoms. Whereas with the lumbar, you're going to tend to see the sphincter involvement a little earlier in the process. And you also have a greater likelihood of having cauda equina syndrome when you have it in the lumbar, because the cone of the spinal cord ends usually between L1 and L2. If the person has cancer and they present with these symptoms and you suspect it, get the MRI. And you don't have to get contrast with it. You get the MRI, call neurosurgery. As soon as you get done with that, putting in the orders for the MRI, you call neurosurgery so they can take a look at the MRI and see whether the person would be a candidate, whether to get a biopsy, whether to get a resection of the tumor, if it's due to a vertebral fracture, to do a kyphoplasty or do a vertebral stabilization. You also are going to want to get radiation oncology involved, whether it's because they may be a candidate for adjuvant therapy after the resection, or if it's determined they're not a surgery candidate, to get radiation for palliative benefit. Again, dexamethasone is your best friend, and pain control is not too far behind. Cardiac tamponade. This is another one I have a story if I actually get done in 30 minutes, Katrina. Most common cause is thoracic malignancies. You also have radiation injury, infection, uremia, hypothyroidism also are risk factors for cardiac tamponade or pericardial effusions, but far and away thoracic malignancies. And you hear Beck's triad, the hypotension, which is due to the decline in the cardiac output, the muffled heart sounds because there's fluid surrounding the heart. You're not going to really hear the heart sounds. Distended neck vein, again, because of this distension of the heart, it's causing the effect. You're not getting good filling in the right ventricle going to the right atrium. So everything's going to back up. And because it's backed up, they're going to be dyspneic. You're not going to get blood flow to the heart or the lung in a good manner. Cough, chest pain, generalized weakness. When you look at all these symptoms and you think the effect of the heart, they all make sense. The tachycardia, the peripheral edema, Kussmaul sign, which plays a role as far as with the jugular venous pressure, and also the impaired filling of the right ventricle, pulsus paradoxus, which you tend to classically think about with cardiac tamponade, where you've got that difference, significant difference in the blood pressure on inspiration. The EKG, you're going to see the sinus tachycardia. The heart's working harder against a lot of resistance caused by this fluid. You're not going to see a good amount of voltage because the electrical impulse is not going to travel well through fluid. And then electrical alternans. And the electrical alternans, it has a high specificity but not a low sensitivity for identifying a cardiac tamponade. But you see it on the, another green one. You see that there where you have the difference in the size of the QRS. That's what we mean by electrical alternans. The echo, the right atrial collapse, right ventricular collapse, that's going to be very diagnostic. That's got a high sensitivity and specificity for cardiac tamponade. Chest x-ray is going to show the water bottle heart, but it'll only show the water bottle heart if there's at least 200 milliliters of fluid surrounding the heart. The diagnosis is definitely made with a pericardial biopsy, and that needs to be done. If it's positive for malignancy, it's a very poor prognosis. Unfortunately, 65 to 85% of patients, again, most common is thoracic malignancy. 65 to 85% of those patients, they have pericardial effusion. It's going to be malignant. When we get to management, asymptomatic, only mild effusion, there's really no emergent treatment needed. If it's symptomatic, you need to get the fluid out. And you can do a pericardiocentesis, but unfortunately 60% of the people have a recurrence or a reaccumulation of fluid and will need to go get the surgical pericardiectomy or the pericardial window. Jessica talked briefly about superior vena cava this morning. 95% of the cases are thoracic. Again, the remaining is central venous catheter. If you see the symptoms, you see what the physical exam would show, the thoracic vein distension, the facial edema, the tachypnea. Chest x-ray is going to show as far as if there is some kind of fluid in the lung. The CT would show if CT will actually show the obstruction, and it'll also show if there's collateral veins being developed by the body to try to bypass the blockage. The diagnosis is made again, get a sample of the whatever's causing the blockage, whether it's a thrombus in the superior vena cava, whether it's extrinsic compression of a tumor, and you'd need to treat the underlying disease, see whether they're a candidate for stenting, see whether they're a candidate for surgery, or if it's a thrombus, thrombolytic therapy. And there are some pictures, and you can see right there, this picture where the arrow ends, that's the superior vena cava. That's almost completely occluded. Just a couple quick ones. GU obstruction with prostate cancer, bladder cancer, retroperitoneal tumors. Whether they're affecting the kidneys, the ureter, or the bladder will indicate what treatment, whether you get a TURP, whether you get a TURB, whether you get stents put in, whether you get nephrostomy tubes put in. And when you have this obstruction, there's an increased risk for infection, so make sure you get the cultures and treat the infection. Leukostasis occurs with acute leukemias. High blast count, see the presentation, see what they can present with, heart failure, and the treatment's leukapheresis. And you can use hydrea as an adjunct treatment to maintain the white blood cell count in a normal range, or relatively normal range. Pulmonary complications, airway obstruction, again, stents, intubation, laser therapy. You may get IR to come in and do IR is the next one. Brachytherapy, massive hemoptysis, I'm talking faster than I'm thinking. Massive hemoptysis, 400 to 600 milliliters in a 24-hour period, resection of the tumor, laser therapy, or have IR come and do embolization. And then toxic lung injury, providing supportive care. Mets, we talked about this, to the bone, treatment, biphosphonates, chemotherapy. If you have an impending fracture, an occult fracture by MRI, or an actual fracture, get ortho involved so they can do their thing. Radiation therapy does a wonderful job of palliative care for bone pain. And then neutropenic fever. ANC, absolute neutrophil count less than 500. Temperature for an hour of 100.4 or one temperature of 101. That's why when you have these people, you tell them not to take Tylenol if they're getting therapy that has a higher risk for neutropenic fever. Pan culture, empiric antibiotics, we try to do it within 45 minutes of them hitting the door because you don't want to have them get sepsis. The other things, typhlitis, which is basically inflammation of the cecum in neutropenic patients, enteritis, inflammation of the colon, talked about thrombus in cancer patients, and if they don't quite get the IV in right for the chemotherapy and you have extravasation, that's the last one. There we go. How we do? Excellent. Do I have time for my stories? Do I have time for my two stories?
Yeah, you have time.
Okay. There's only two, the hypercalcemia and the pericardial effusion. The hypercalcemia is recent because, remember I talked about the rapidity increase? I had a patient who came in and her total, or their corrected calcium was 9, and we had her on IV fluids that continued the trend up, and you usually don't give them biphosphonates until it gets past 12 into 13, and she was slowly going up. She was the only symptom she had was constipation. But once she hit 13 that day, you could barely wake her up. She couldn't stay awake. She was very, very lethargic. So we gave her I think we gave her the zolindronate, and it took a couple days, but even the next day she was much more awake, much more alert. So that's why I was saying there was that rapidity increase, how in a matter of days it went from she was sitting there fine, wanting to go home, to couldn't even stay awake. Besides, she had a bowel movement like a week before she came in, but aside from that. So that's kind of brings home the rapidity of the increase. The pericardial effusions, it's gotten to the point where thoracic surgery almost would rather stay away, at least based on our recent experience, stay away from pericardial windows and everything else. I had a patient who was found to have a pericardial effusion. The echo said no impending cardiac tamponade. You could listen to her heart, clear as a bell, no distension. The only thing she had was a cough, and she just felt a little bit more short of breath. That's it. And thoracic surgery saw her, said we'll do a pericardial window the next day. She went into tamponade that night, never made it to the next morning. 10% of cancer patients on autopsy have pericardial effusions. One of the thoracic surgeons, APPs, was telling me they try to stay away from them because they had 4 patients that they did pericardial windows on for the pericardial effusion, and all 4 of them passed away. They felt it might have been better off just letting them treat the symptoms and not expose them to the surgery. And so I'm not sure what the experience is in other cancer centers, but yeah, thoracic surgery is a little more hesitant, at least when I've talked to them about doing pericardial windows. Those are the 2 stories. That's it. Thank you.